Hey, Dr. Karan from Dr. PK Life. So, in this long video, I'm going to talk about different kinds of heart attack, um, STEMI and non-STEMI. A STEMI is ST elevation myocardial infarction. STEMI, STEMI, is caused by complete blockage, complete occlusion of a coronary artery, usually by a thrombus over a ruptured atherosclerotic plaque and results in transmural ischemia, means injury through the full thickness of heart muscles called myocardial wall. It leads to classic ST elevation on EKG because of current of injury across the entire ventricular wall. Other one is non-STEMI, non-ST elevation myocardial infarction, and it's caused by partial occlusion or severe narrowing of coronary artery and results in subendocardial ischemia, which is damage limited to 1/3 of myocardium, heart muscles, and which is most vulnerable to low blood flow. And there is no ST elevation in EKG, but can show ST depression or T wave inversion on EKG. So, what's happening in these two situations? Blood flow is compromised and there's a myocardial damage. In STEMI, there's a complete blockage, full thickness myocardial infarction, and if reperfusion is delayed, and the damage is more extensive and it causes necrosis of heart muscles. And non-STEMI, which is incomplete blockage, it leads to either intermittent obstruction and there's a partial ischemia and a smaller subendocardial infarction, but it still carries a high risk. In EKG finding, in STEMI, there is a ST segment elevation in the EKG, and non-STEMI, there is a ST depression or T wave inversion, and there is no ST elevation. Cardiac biomarkers in both infarction, troponin, which is the enzyme from the heart muscle, troponin T on CK-MB, they are elevated, confirming myocardial damage. Difference is that in STEMI, because of larger damage of the muscle, the troponin T level, it shows higher peaks due to larger necrosis of the heart muscles. Clinical implication, STEMI is a time critical emergency because you want to save the heart muscles, because completely necrosed, then there's a less chance of survival. And so it requires immediate reperfusion therapy, PCI, angioplasty, or fibrinolysis, where they give clotting buster medication. Non-STEMI is managed urgently, but there's no immediate risk. So usually they don't do angiogram, angioplasty unless patient become unstable. In this patient of mine, they watched his troponin. He was basically asymptomatic later on, and he has 3 sets of enzymes were high. He was rushed to the cardiac cath unit, but they didn't do angiogram, and they discharged him later on some medication. But the thing is, the guy is refusing to take cholesterol lowering medication. So that's the difference. And think of this: STEMI is a full thickness infarction from full blockage, versus non-STEMI is a partial infarction from partial blockage. And what you need to understand is that not all heart attacks are same. So question is, what causes heart attack? I mean, the blood is compromised, blood flow is compromised, and it's only because of atherosclerosis and rupture of the plaques. This guy has a cholesterol of 270, LDL of 140 plus, but no family history, no history of smoking. So his risk factor was only hypercholesterolemia and age and male gender. So Obviously, he had some atherosclerosis, but he had a stress test done, which was negative, that ruled out any critical stenosis of coronary artery. So it's important to manage the risk involved. So in this guy, it's important that his cholesterol is managed better. He also needs to be on a small dose of aspirin, 81 milligram, along with high dose of statin, like 80 milligram of atorvastatin. So he's going to be seeing cardiologist. He said he's going to wait until he sees a cardiologist before he starts medication. But I told him that he's still carrying the risk. It might happen again because his risk factor has not changed what caused initially. So sometimes it's kind of difficult to deal with those kind of patients. They are recalcitrant in their approach and their belief, and they just don't want anything. They don't want to take any medication because they've been told a statin is bad for you. Fact is that a statin is not bad for you. If you have a risk factor, statin is not bad for you. You have to outweigh the benefits and any harm it might do to you. And cholesterol needs to be controlled. Cholesterol needs to be managed appropriately, because this is the single most risk factor for a stroke and heart attack, which can be managed by simply taking one pill. So if you have cholesterol problem, don't delay. Talk to your doctor. Start taking a statin. If not a statin, you have other option, non-statin medication, but they're not usually as effective. So, talk to your doctor and think about it and consider taking a statin. A statin saves lives. Thank you for watching.